afternoon. My name is Renske Wiersema, and I'm very delighted to be able to talk to you today about the ultrasound use for acute kidney injury. I work in the Netherlands in Groningen and as a postdoc researcher in critical care, and I recently finished my PhD on acute kidney injury. Today, I would like to talk to you a bit about ultrasound and acute kidney injury, as mentioned. And first, I'd like to share with you the definitions of acute kidney injury, various causes in critically ill patients. I would like to shortly mention shock and venous congestion, two important concepts. And lastly, and most importantly, I will focus on which types of ultrasounds you may be able to use for acute kidney injury, specifically in this group of critically ill patients. So we start with acute kidney injury. Various people become sick and then of course present to the emergency department, of which a part becomes admitted to the ward, but if they're very critically ill or hemodynamically unstable, they may get admitted to the ICU, the intensive care unit. And a part of these people get acute kidney injury and a part of these people don't. Up to a decade ago, we thought the incidence of acute kidney injury was about 30%, but last years we have shown that almost 50 to 60% of patients admitted to the ICU acutely get acute kidney injury. And we are still not quite sure why and which patients get acute kidney injury. Also, the severity is very different, ranging from a short period of oliguria until 4 days requiring renal replacement therapy. Nonetheless, the consequences are very important. On the short term, outcomes may be impaired by having to need renal replacement therapy and elongate the ICU stay. But on long term, we see that patients who had acute kidney injury may actually end up having impaired kidney function and becoming dialysis dependent. This, of course, may very gravely impact quality of life. So acute kidney injury, what is it exactly? Well, it happens in up to 50% of critically ill patients, but it's a persistent and or temporary decrease in renal function. And this is defined based on serum creatinine rises and urine output decrease. Serum creatinine rises often a bit late, so mostly a day or even 2 days after renal injury has taken place. And urine output may stop abruptly. But the exact role of hemodynamics remains unclear. But what is very apparent is that in the ward, the incidence of acute kidney injury is way lower than in the ICU. So we need to find some reason why there's such a discrepancy. And of course, patients in the ICU are sicker, which is probably a very important explanation for this discrepancy. But there's also this kind of hypothesis that it also has a lot to do with hemodynamic variables. And it has been shown that arterial function is associated with the development or the progression of acute kidney injury, with arterial function being variables like blood pressure or the amount of noradrenaline that is needed to keep the good blood pressure up. But there's also increasing evidence for venous congestion. And venous congestion is a concept which entails venous fluid overload, meaning that there's too much fluid in the system for the right heart to be able to pump away. And that this, instead of forward failure, may cause backward failure for the kidney, causing some sort of disruption in the outflow and therefore also decreasing or impairing renal function. And there are multiple proxies to measure venous congestion, as this is mostly a concept, for example, by using fluid balance, but also right heart function or even ultrasound of the kidney. These things I will get back to later. There are various ways to define acute kidney injury. As I said, they are always based on the use of serum creatinine and urine output. And most recently, the KDIGO criteria were released, which has been used since 2012. But as we see, based on how you apply these criteria, for example, only using urine output or using only serum creatinine, in one same cohort, the incidence can range from about 20% to about 75%. And this is a very important thing to keep in the back of your head, because when you compare different cohorts or studies, you always have to pay attention to what definition was used to define acute kidney injury. There are various causes of acute kidney injury in critically ill patients, and it's almost never one cause. For example, we try to define and split it up into 3 major categories, being pre-renal, intrinsic renal, and post-renal causes of acute kidney injury. Pre-renal usually concerns hypovolemia, shock, but maybe also congestion. Intrinsic is more focused on infectious causes, specifically in the kidney itself, but also nephrotoxicity of the various drugs that may be used in the intensive care unit, and also vascular pathologies, so as, like renal artery stenosis. Last, we have post-renal causes of acute kidney injury, which may include intra or extra-renal obstruction, which can be seen on the ultrasound as hydronephrosis. This is a very clear cause of acute kidney injury, but in ICU patients, this is mostly only 10%. So when we get to acute kidney injury in ultrasound, we see that there have been various studies about this, both going in very specific proxies, such as ventricular function of the heart and acute kidney injury, but also using whole body assessment. For example, the VEXUS score, which has been recently been published. It's a very interesting study, which also includes ultrasound of the liver and of the vena cava. On the top right, you see a study concerning Doppler ultrasound, which is specifically looking at the kidney to be able to predict acute kidney injury or the persistency of it by looking at the flow in the renal vessels. It has been an up-and-coming technique, and it's very easy to do, and therefore it's also so popular and is the research up-and-coming to assess what value it actually brings. But what is important to note is that besides looking for specific causes of acute kidney injury, ultrasound can be used to look at the whole body and get a sort of feeling of the fluid status of the body at that moment. For example, assist patients in shock or assist patients actually having venous congestion, which can both result in a low blood pressure, but require very different treatment strategies. Treatment for acute kidney injury doesn't really exist, in that it's very hard to cure. So all we do at this moment is support renal function and try to get rid of the causes that may be there. For example, to stop all nephrotoxic drugs, and if needed, support renal function with renal replacement therapy. So if we look at acute kidney injury and ultrasound, we can look at the specific causes, or we can take a whole body approach. And with that whole body approach, I would like to start with this figure. So if we go from top to bottom, we can see that impaired left ventricular function can cause acute kidney injury by having a bit of forward failure and not providing enough blood for the kidney to sustain the glomerular blood flow that is necessary for appropriate renal function. On the other hand, we can also have impaired right ventricular function, which can cause this so-called venous congestion. For example, with a congested inferior vena cava, causing increased renal venous pressure, increased interstitial pressure, and also increased tubular pressure. This, all in all, can decrease the glomerular filtration rate and thus cause acute kidney injury. Last but not least, of course, abdominal extrinsic pressure on the kidney can also impair renal function. And as more and more evidence accumulates, it has been shown that these are all risk factors for acute kidney injury, but it's still unsure if it's actually causative. And there is also a discussion whether it's cause or consequence. So we need to await randomized controlled trials to see whether we could actually also have fluid removal and then see if that actually improves renal function in these patients. So if we look at this picture, we also see pulmonary edema. And pulmonary edema can be a severe sign of congestion. And that's why I want to show you guys some ultrasound images which can actually show signs of venous congestion or even shock. And these two things can both help in assessing the patient with acute kidney injury to treat or support the body in its underlying cause. To start with pulmonary edema. In pulmonary edema, of course, we try to use our stethoscope and see if we can hear fluid behind the lungs. But ultrasound in the lungs is quite easy, following the protocol by Professor Lichtenstein. And in here we see that there are various B lines dancing through the image, indicating that there is fluid in the space where it shouldn't be, i.e. this may be a sign of pulmonary edema. But then to assess cardiac function, we can see various things. We can see both a very enthusiastic heart with no signs of right ventricular overload and a well-performing left ventricle. But in ICU patients, this may also very well be different with a left ventricle that's hardly moving, or a right ventricular function that looks quite all right, but then when Doppler is used, quite an impressive tricuspid regurgitation is seen. Another thing which can be shown using ultrasound is the inferior vena cava. This is important to note that it is difficult sometimes in ICU patients, as these are often being ventilated, which also rises intrathoracic pressure. And also it's very important to identify the inferior vena cava on two planes to make sure that you have the right vessel. But if and when you do, you can actually see whether the inferior vena cava collapses, i.e. when there is space still to collapse for it, because this is normal. And if it doesn't, this may be a sign of venous congestion as well. And last but not least, we have renal ultrasound, which you can use to both exclude hydronephrosis, which I will get back to later, but also actually to see and envision the renal vasculature. And in this image, you can perform various measurements, of which most have been on the arterial function, the renal resistive index, but also most recently, some new studies have shown that the venous impedance index, so actually showing how the pressure differences in the renal veins, may also predict acute kidney injury. The latter really has more connection with the concept of venous congestion, of course, because it translates back to the higher pressure, for example, in the vena cava and in the right ventricle. However, in 2018, a very nice study was published by Michael Darmon et al. In intensive care medicine in about 350 patients, which showed that the performance of this Doppler-based renal resistive index was actually quite limited. So the diagnostic accuracy was quite low, and it therefore was perhaps not appropriate to use as a clinical tool. This study, however, didn't include the venous impedance index, and that's something in the light of the concept of venous congestion, which may offer a higher discriminative accuracy. And a study that recently was published that did that from Paul-Bien-Sologny in the ultrasound journal used the VEXUS score, which is a newly developed score, to not only look at the intrarenal venous flow, which is the lowest ultrasound image, but also in the liver to see whether the flow in the venous system was actually influenced by intravenous pressure. And which you can see in the table below here is that they developed multiple grades to assess venous congestion, and that they showed in their study that actually this score outperformed central venous pressure in predicting acute kidney injury. Last, of course, we have the post-renal cause for acute kidney injury, which may be due to, for example, a kidney stone causing hydronephrosis. And in the left part, you see here that there is a sinus visible, very nicely graphically shown with below the ultrasound image, which shows that there is only some distension. But on the right side, you see that the parenchymal compromise is happening, so that there is almost no room for normal renal parenchyma, indicating a very severe hydronephrosis, which can very well cause acute kidney injury, which will cause acute kidney injury. So if we look at this picture, which is a very nice graph, also adopted from the study I mentioned earlier, is that you can use ultrasound in various stages to look at acute kidney injury. On the top hand left, you can identify potential reversible factors, for example, the hydronephrosis here in the top left, but also evaluate the hemodynamic assessment, not only by looking for causes of shock, but also by, stated here below, detecting fluid overload, using, for example, portal Doppler in the liver, but also lung ultrasound to spot extreme pulmonary edema as a sign of venous congestion. Of course, the next step is still to see whether in an RCT this actually helps, and it also whether it actually helps also in these patients to promote fluid removal early on, and to see whether that actually increases renal function. It's important to mention that ultrasound always has pitfalls. So also when assessing patients with acute kidney injury, ultrasound remains operator dependent, and of course, specifically in critically ill patients, you often have a suboptimal image quality, which may actually prevent from appropriate interpretation of the images. And what happens in some studies is that if we don't get a proper images, we tend to exclude these patients. But this may cause a bias because, of course, the images get, for example, less well if a patient is more sick, or if a patient has a higher body mass index, which can actually cause that the patients that we do include do not represent the whole population that we would like to study. And lastly, for hydronephrosis, these are only a few of the pitfalls in ultrasound. You shouldn't get fooled by renal cysts. I've had it 2 weeks ago that there was a cyst very close to the renal pelvis, and that can very well imitate a hydronephrosis. But renal cysts are very common and can be asymptomatic. So try to get a proper image and see whether it actually has a connection with the renal pelvis or whether it's a solid but lucent mass. So in conclusion, acute kidney injury in critically ill patients is almost never due to a single cause. When it is due to hydronephrosis, it's only in 5 to 10%, and is likely one of the most heterogeneous syndromes, which also makes why you can use ultrasound for acute kidney injury by assessing the whole body. And this means you looking at the lungs, looking at the heart, looking at the vena cava, looking at the liver and at the kidney itself. And ultrasound can then help you by estimating cardiac function to see whether it's forward failure or backward failure, or maybe a bit of both, but also by estimating fluid status, of course, which is relevant for the fluid academy we're currently busy in, for optimal fluid administration. And this means that you also have to repeat your ultrasound to see whether the actions that you're taking are actually having an effect on what you're doing. And lastly, of course, it's very useful to exclude post-renal causes in the diagnosis for acute kidney injury. Thank you very much for your attention.